Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 148 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, you are the antimicrobial stewardship pharmacist on call. The clinical microbiologist calls you with critical values of a rapid diagnostic result. He informs you that patient has a positive blood culture with Escherichia coli, which is positive for the CTXM gene. While reviewing the patient chart, you notice that the patient's chief complaint on admission was a urinary tract infection, UTI, and was initiated on ceftriaxone. So my question to you is, which of the proposed therapeutic changes listed below would be the most appropriate to recommend in TMM's clinical scenario now? Would it be A. switch to ertapenem, or B. switch to cefepime, or C. switch to piperacillin, tazobactam, or would it be D. continue ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. switch to ertapenem. CTXM is the most common type of ESBL in the United States. Ceftriaxone, answer A, would be inappropriate for ESBLs. Piperacillin, tazobactam, answer B, has limited usefulness in ESBL infections when the MIC is unknown. Unless the MIC is known, piperacillin, tazobactam would not be an appropriate empiric choice. Cefepime, answer C, does not have reliable activity against ESBL and would not be an appropriate empiric option. Carbapenems are usually the empiric choice in ESBL infections, and because this is Escherichia coli, anti-pseudomonal activity can be spared. Let's move to the next question, please. And the next question reads, STP, a 24-year-old female patient presents to your accident and emergency department with a chief complaint of fever, with a body temperature of 101 degrees Fahrenheit, chills, malaise for the past few weeks after sharing a needle with an acquaintance. Regarding her past medical history, she is a known intravenous drug user, IDU, and her preferred drug is methamphetamine. She has already had a prosthetic tricuspid valve replaced after an episode of methicillin-resistant Staphylococcus aureus (MRSA) endocarditis treated with vancomycin at the age of 21 years. Her pertinent labs and vitals include a WBC of 18.4 times 10 power 3 cells per millimeter cubed, a heart rate of 106 beats per minute, a blood pressure of 106 systolic 60 diastolic, and a respiratory rate of 18 breaths per minute. Her blood cultures turn positive in 8 hours, with all bottles reporting gram staining as gram-positive cocci, probably staphylococci. So my question to you is, which of the treatment and associated reasoning listed below would be most appropriate in this clinical scenario? Would it be A. Initiate dalbavancin, because this patient should not have a peripherally inserted central catheter, abbreviated as PICC line, or B. Initiate ceftaroline, because lipopeptide resistance follows glycopeptide resistance, or C. Initiate vancomycin, because this is a separate episode from her prior infective endocarditis, i.e., or would it be D. Initiate tigecycline, because she has had vancomycin before, so this is likely resistant. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Initiate vancomycin, because this is a separate episode from her prior infective endocarditis, i.e. Staphylococcus aureus is virulent, and if this were a continuation of the same episode of endocarditis as before, the patient would likely not have lived for 3 years. She also has had risk factors for reinfection since the first episode, continued intravenous drug use, thus, this is most likely a new infection, for which vancomycin would be an appropriate empiric option. Answer C is correct. Because of this, there is no need for tigecycline at this time, therefore answer D is wrong. Although lipopeptide can sometimes correlate with glycopeptide resistance, there is no evidence at this point that there is resistance, and ceftaroline evidence lies in use for salvage therapy, not empiric therapy, therefore answer B is wrong. Although this patient is a poor candidate for a PICC line, this is empiric therapy and is not the time for dalbavancin use, therefore answer A is wrong. Dalbavancin has few data for endocarditis, and the dosing for that indication is not well known. Let's move to the next question please. And the next question reads, STP is transferred to the MICU 72 hours after admission due to hemodynamic instability. Her blood cultures grow MRSA with a vancomycin MIC of 2 mcg per milliliter and a daptomycin MIC of 0.5 mcg per milliliter. High dose, that is, 10 mg per kilogram, daptomycin is initiated. She is too unstable for surgery now. On hospital day 8, STP has persistent MRSA bacteremia. So my question to you is, which of the therapeutic modifications suggested below would be the most appropriate in this clinical scenario now? Would it be A. Add linezolid to daptomycin, or B. Add vancomycin to daptomycin, or C. Add nafcillin to daptomycin, or would it be D. Increase the daptomycin dose to 12 mg per kilogram? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Add nafcillin to daptomycin. This patient has refractory bacteremia that should have responded to high-dose daptomycin alone, and 10 mg per kilogram is the guideline-based recommendation. There is no evidence for additional benefit with increasing the daptomycin dose in this situation because there appears to be some tolerance to daptomycin, therefore answer D is incorrect. There is little evidence to support adding vancomycin to daptomycin and no suggestion of synergy, therefore answer B is incorrect. There is little evidence to support adding linezolid to daptomycin and no suggestion of synergy. This patient's drug of choice is methamphetamine, thus, a linezolid-containing regimen would not be sustainable if she went back to intravenous drug use, therefore, answer A is incorrect. Data exist for adding anti-staphylococcal penicillins to daptomycin for MRSA, and the combination is synergistic, therefore, answer C is correct. Let's move to the next question, please. And the next question reads, PLJ, a 42-year-old male patient with a past medical history significant for acute myeloid leukemia is admitted to your hospital. He is day +2 from an allogeneic stem cell transplant. He has chief complaints of mucositis, nausea, and vomiting. His pertinent vitals and labs include an absolute neutrophil count, ANC of 0. He develops a fever, with a body temperature of 100 degrees Fahrenheit. Blood, peripheral and from port, and urine, clean catch cultures are collected, and his regimen is switched to cefepime, vancomycin, and micafungin. The blood cultures remain clear. The urine culture shows greater than 100,000 colony-forming units per milliliter of Enterococcus faecium that is susceptible to daptomycin, with an MIC of 2 mcg per milliliter, linezolid with an MIC of 1 mcg per milliliter, nitrofurantoin with an MIC of 16 mcg per milliliter, and tigecycline with an MIC of 0.064 mcg per milliliter. Because the patient's status is tenuous, a temperature 102 degrees Fahrenheit overnight and blood pressure of 110 systolic 55 diastolic, the team requests an antibiotic recommendation from you as the clinical pharmacist specialist in the infectious diseases team. So my question to you is, which of the antibiotics listed below would be the most appropriate in PLJ's clinical scenario? Would it be A. linezolid, or B. daptomycin, or C. tigecycline, or would it be D. nitrofurantoin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. daptomycin. The patient has mucositis and nausea or vomiting, thus, an oral choice like nitrofurantoin would not be ideal. There is typically a desire for more systemic treatment in patients with neutropenia, and nitrofurantoin is not a systemic antibiotic, therefore answer D is incorrect. Tigecycline has poor urinary penetration 30% and, as monotherapy, has had poor outcomes, therefore answer C is incorrect. The patient already has neutropenia, and linezolid can cause further neutropenia. There is also concern in using bacteriostatic antibiotics in patients with neutropenia, therefore answer A is incorrect. Daptomycin has good urinary penetration 70% and would provide systemic coverage until the counts recover, therefore answer B is correct. Let's move to the next question, please. And the next question reads, PLJ, in the case above recovers from his UTI, on the antibiotic recommended by your ID physician. His counts are recovering, his WBC count is 4.3 times 10⁻³ cells per millimeter cubed. His antibiotics are de-escalated appropriately, and he is placed on prophylactic fluconazole and acyclovir. It is now hospital day 20, and PLJ is stable for discharge, except he has another fever, with a body temperature of 100.6 degrees Fahrenheit. His blood cultures are collected and submitted to the microbiology lab, and his discharge is placed on hold. The following culture results are reported. Enterobacter is grown, and cefepime IV 2 grams twice daily is reinitiated. Final susceptibility results are as follows: amikacin susceptible with an MIC of 8 mcg per milliliter, cefazolin resistant with an MIC greater than 64 mcg per milliliter, ceftriaxone resistant with an MIC of 16 mcg per milliliter, cefepime susceptible with an MIC of 4 mcg per milliliter, meropenem susceptible with an MIC less than 0.25 mcg mcg per milliliter, piperacillin, tazobactam resistant with an MIC of 64 mcg per milliliter, tobramycin susceptible with an MIC of 1 mcg per milliliter. So my question to you is, which of the regimens listed below would be most appropriate in PLJ's management now? Would it be A. Change to tobramycin 7 mg per kilogram IV once daily, or B. Change to meropenem IV 500 mg 4 times daily, via extended infusion over 3 hours, or C. Increase cefepime 2 grams IV twice daily to thrice daily, or would it be D. Continue cefepime 2 grams IV twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Increase cefepime 2 grams IV twice daily to thrice daily. Enterobacter are consistently carriers of AMP-C, and this susceptibility pattern suggests this is an AMP-C, which is resistant to third-generation cephalosporins. It is susceptible to cefepime, but MICs of 4 to 8 mcg per milliliter are susceptible dose-dependent, abbreviated as SDD, for which the recommended dose is 2 grams every 8 hours, therefore answer C is correct, not 2 grams every 12 hours, and answer D is incorrect. Cefepime has emerged as a carbapenem-sparing option for AMP-C, and meropenem would be unnecessary escalation, therefore answer B is incorrect. For bacteremia, aminoglycoside monotherapy would not be ideal and is associated with poorer outcomes, therefore answer A is incorrect. Let's move to the next question please. And the next question reads, OMO, a 52-year-old female patient presents to your hospital with a past medical history significant for hypertension and gastroparesis. She has an implanted gut stimulator, a PICC line, and is receiving home TPN. She was admitted for observation after exchange of the stimulator wires. Post-operatively OMO developed a fever, with a body temperature of 100.7 degrees Fahrenheit. 24 hours later, her WBC had increased to 18 times 10 power 3 cells per millimeter cubed. At baseline her WBC was 6.9 times 10 power 3 cells per millimeter cubed. Her blood and urine cultures grew yeast. She was initiated on micafungin. The cultures were finalized as Candida glabrata. The Candida glabrata is susceptible to amphotericin B, susceptible dose-dependent with respect to fluconazole and susceptible to both caspofungin and voriconazole as shown in the table summarizing the susceptibility results. According to protocol, she receives an ophthalmology examination, which reveals endophthalmitis. So, my question to you is, which of the antifungal regimens listed below would be the best for OMO now? Would it be A. Voriconazole 4 mg per kilogram IV twice daily, or B. Fluconazole 800 mg IV once daily, or C. Fluconazole 400 mg IV once daily, or would it be D. Micafungin 100 mg IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Voriconazole 4 mg per kilogram IV twice daily. This patient has endophthalmitis and needs an agent with CNS penetration. Micafungin does not have CNS penetration and is not recommended for endophthalmitis, therefore answer D is incorrect. Fluconazole does have CNS penetration, but the organism is susceptible dose-dependent (SDD), and 400 mg is too low, therefore answer C is incorrect. Fluconazole 800 mg would be appropriate for most SDD infections, but the peak in CNS would not be high enough to overcome this MIC of 32 mcg per milliliter, therefore answer B is incorrect. The Candida glabrata is reported as susceptible to voriconazole, which has CNS penetration. It would be appropriate for endophthalmitis, therefore answer A is correct. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 149.